From the myeloid lineage, you are going to see certain cells which arises from your myeloid lineage. That are your erythroblasts, your myeloblast, your monoblasts, and your megakaryoblast. Okay. Then you have lymphoid lineage from which you are going to see two cells arising, that is B lymphoblast and T lymphoblast. As the name indicates here, the blast mean they are immature cells and they need further maturation. Like your erythroblast, whenever they are mature, they are going to be converted into red blood cells, right? Your myeloblasts, when they are mature, they are going to convert into granulocytes, that is neutrophils, basophils, and eosinophils, right? And monoblast is going to be converted into monocytes, right? Monocytes, when they enter the tissues, they are going to be converted into, yes, guys,
Macrophages.
macrophages. Okay. Megakaryoblast, they are going to be converted into megakaryocytes, right? And then they are going to be converted into platelets, right?
Yes.
Okay. Then you have your B cells. B lymphoblasts that are immature, T lymphoblasts are also immature. They are also going to undergo maturation process. That is, first of all, they are going to be converted into naive B cells, and then B cells is going to be converted into plasma cells, right? And plasma cells, after the class switching, it's going to give you antibodies. Okay, T lymphoblast is going to be converted into naive T cell, and then it's going to be converted into CD8 positive and CD4 positive, helper and killer cells, if you guys remember, right? So, okay, so guys, can you just tell me the normal level of WBC? What's the normal range?
4,000 to 11,000.
Okay, it's 4 to 11, right? So, whenever the white blood cell count is greater than 11,000, then we use a term for it, that is leukocytosis, right?
Yes.
When greater than 11,000, and whenever they are less than 4,000, basically, what's the term used for that? Leukopenia, right?
Leukopenia.
You like leuco for your white blood cells and penia it's less. Okay, so let's discuss some of the causes of leukopenia. Okay, so it's, that your white blood cells are also like high turnover cells. It means they keep on actively dividing. For example, like on daily basis, you are going to encounter thousands of bacterial infections, and you are going to see turnover of like millions of white blood cells, right? So it means they are actively dividing cells. So, for example, if a person is having certain metastatic, like malignant cancers, and we are giving him with radiotherapy or chemotherapy, it means all of the dividing cells are going to be affected. Yeah, like all of the metabolically dividing cells, including white blood cells, can be affected, and they can become leukopenic, right, or less than their normal 4K. Simple. So it means chemotherapy and radiotherapy can cause leukopenia, right? Okay. What if there is severe infection? Okay, normally we are thinking of whenever there is infection, the leukocyte count should increase. But whenever we have severe infection, what happens? Like for example, in gram-negative sepsis, all of your white blood cells are going to move towards the site of infection, and as a result of that, what's the idea? The white blood cells in your blood are going to become less. So it can also be the severe infection. Remember, severe infection, right? Can also be cause of one of the cause of leukopenia, right?
Yes.
Same is the case with lymphocytes. Like for example, okay, in which condition will be seeing lymphopenia? You know, guys, the condition lymphopenia. Let me give you one of hint. That is failure of third and fourth pharyngeal pouches when formed. So what happens?
DGH syndrome.
Okay, DiGeorge syndrome, thymic aplasia, T cells do not mature. If you do not have measured T cells, can I call it lymphopenia?
Yes.
Okay. What about, okay? So the first one is your DJOD syndrome, right? Okay. The second one, in high cortisol state, you guys have already learned the physiology of cortisol. That cortisol basically induce apoptosis of your lymphocytes, right? So it kills your lymphocytes. And what does it do to leukocytes?
Leukocytosis?
Yes, it increases white blood cells count. How? I have just did it multiple of time. Bats sitting in the
And
cave.
decreases the neutrophil chemotaxis.
Yes, bat in the cave, hanging in your pulmonary vasculature, your neutrophils. It decreases the adhesion, and all of these neutrophils are going to leak into your blood. So it would induce leukocytosis, right? But it would kill your lymphocytes. Okay. Thirdly, what about autoimmune destruction? For example, in SLE, you
Yeah,
are
it
seeing
will
that,
cause leukopenia.
yes, it can cause lymphopenia, right? Okay, similarly, all of the body, like complete body radiation, can also affect your lymphocytes as well because they are also actively dividing cells. Now, let's discuss some of the causes of leukocytosis. The condition in which your white blood cells are going to increase, you guys know, infection. Not severe infection like bacterial normal infection. It's going to increase your WBCs, right? In order to fight off. Okay. What about cortisol? Here we discuss cortisol, right? It also causes leukocytosis. Okay. So perfect. Okay, so there can be certain condition. For example, you guys know that the neutrophils basically are increases in infections. The eosinophil basically increases in like you guys can think of the mm, hypersensitivity reactions, right? Parasitic infiltrate like helminths, eosinophils count rises. Similarly, in chronic inflammation or chronic infection, you are going to see monocyte rise as well. Okay, so these are some of the reasons in which different cell lineages can arise, right? Basophils, basophil also increases in chronic myeloid leukemias, which we'll be discussing. Basophilia, CML, if you guys remember. Okay, which we'll be doing further. Similarly, if a person is having viral infection, we already discussed in viral infection and fungal infection, you are going to see T cells being increased, right? Already discussed. Okay, so let's discuss one of condition that is known as infectious mononucleosis. Okay, so what do you guys know about infectious mononucleosis?
If Epstein-Barr virus
Okay,
infection,
perfect. Epstein-Barr virus is going to attack which cells?
B cells,
T cells?
B cell.
B B
Okay,
B
B
cells.
cells. That is a CD21 receptor, right? And it's going to attack your B cells, but in response, you are going to see reactive CD8 cells, right? This is one of your UWorld MCQs as well. They are going to ask you a
Yes.
person is having cervical lymphadenopathy. Okay, it is also known as kissing disease, right?
Yes.
Okay, cervical. So it means that it's going to attack your B cells, but as a response of B cell attack, you are going to see CD8 positive T cells being raised, right? Also known as kissing disease. Okay, it can affect your oropharynx. Okay, it can also affect your spleen, right? Because if you are seeing more B cells and T cells, what's the idea? What's the idea, guys? The white pulp of the spleen can undergo hypertrophy or hyperplasia, so it can cause splenomegaly, right? So basically, those individuals who have infectious mononucleosis, we tell them to avoid contact sports. Contact sports. One of your UWorld MCQ, right? Because they can have splenic rupture. Hello? Are you guys getting me? This is also one of your UWorld MCQ. Okay. So if we have CD8 T cells, okay, as we talked, that it's going to attack your CD21, that is B cell. but you are going to see reactivity or increased concentration of CD8 reactive cells, right? So it means, okay, CD8 positive T cells sit in which area of your lymph nodes? Yes,
Mm,
guys.
the cortex,
Paracortex.
paracortex. Yeah.
Perfect. So you are going to see paracortex hyperplasia.
Mm-hmm.
If it's hyperplastic, so it can lead to lymphadenopathy, right? So you're going to see generalized lymphadenopathy. Okay, similar, where did the T cells sit in the spleen? Yes, Dr. L. Futures. In the last lecture, I asked you 2 to 3 times this question. Now again, tell me, T cells are, yes, perfect, periarteriolar sheath.
Mm.
Again, you tell me wrong, but it's okay. Periarteriolar sheath, your arteries, the white pulp, it's going to sit. Okay, so it means that spleen is also going to be enlarged. Okay, and just tell them to avoid contact sports. Okay, so, an interesting thing, you're going to see a monosport test. Okay, there is a test that is known as monosport test. What's monosport test?
Never heard of it.
Okay, so what happens, they are going to make certain antibodies that would be reactive against, yes, horse and sheep red blood cells. That is heterophile antibodies. That is IgM. They would be producing certain IgM antibodies that would cross react to the red blood cells of horse and sheep. Interesting, right? It's known as monospot test. It is one of your U old MCQ.
Yes.
Monospot test. So whenever you inject red blood cells from horse and sheep, they would be having an antibodies against horse and sheep. Okay, so it's interesting. So okay, the negative monospot test. Okay, it can also be caused by EBV as well as another virus, cytomegalovirus as well, but less common, right? Hello.
Yeah.
Okay, so what's the definitive diagnostic? Just do serology for your EBV virus, capsid antigen, right? You have a capsid, Just see whether the viral capsid is present in these individual or not. It would confirm.
Mm-hmm.
Okay, what are some of the complications? Tell them to avoid contact sport. What is one of the treatment option for them? Ampicillin. Give them ampicillin, right?
Mm-hmm.
Okay. So now let's discuss leukemias, acute leukemias and chronic leukemias. Anyone who can just tell me what's the main difference between acute and chronic leukemia? Perfect. Perfect. So the only difference which we can which can differentiate both of these conditions as whenever you have neoplastic proliferation of your blast cells. Okay, these are your blast cells. Here, your blast cells, that is basically known as your acute leukemia. But if you have neoplastic proliferation of your mature cells, then it's basically known as chronic
Mm-hmm.
chronic leukemias, right? So now let's discuss. Okay, so what happens whenever the blast cells are, okay, one of your U world MCQ greater than 20%, right? When the blast cells are greater than 20%, it means we would tell them that they have acute leukemia, right?
Right.
Acute leukemia. Okay. For example, if the blast cells are increasing in concentration inside your bone marrow, it means it's going to disrupt the other lineages as well. Hello? So it's going to disrupt the normal hematopoiesis as well, right? So you'll be seeing pancytopenia. Okay? Like you'll be seeing some bleeding disorder along with that anemia. You can see it, okay? So blast cells. Okay, so now let's differentiate. For example, if we have blast cell neoplastic proliferation, it can either be in the myeloid lineage or in the lymphoid lineage, right?
Right.
Like both have blasts. So it means there are two types of acute leukemias. Either it can be acute myelogenous leukemia or acute lymphocytic leukemia, right?
Right.
Okay. So now let's discuss acute lymphocytic. What's acute lymphocytic leukemia? Already we have discussed when the blast cells are greater than 20%.
Mm-hmm.
What's myeloid when the blast cells are greater than 20%? Simple.
Mm.
Okay. So, okay, now the question arises that how to differentiate whether it's a myelogenous, like a myeloid lineage, or it's a lymphoid lineage. Simply, in myeloid lineage, you are going to see myeloperoxidase. If you
MPL.
guys remember what's myeloperoxidase in respiratory system,
Mm-hmm.
it's going to kill your bacteria, right? You
Right.
have an MCQs on it too. It give you green color of sputum.
Green sputum. Mm.
Yes, this is one of your UWorld MCQ. So this myeloperoxidase, like acute myelogenous leukemia, have myeloperoxidase. It would precipitate in the inside the cell, and it would give you structure of a rod that is known as or rod.
Or rods.
Okay, but it's only present in the blast form, not in the mature form, right?
Mm.
Okay. On this side, acute lymphocytic leukemia, it's simple. It's a lineage of lymphocyte. You're going to see TDT. What's TDT? It's a DNA polymerase,
Mm-hmm.
right? So, okay, we were discussing about acute leukemias. So, acute leukemias can be divided into two types. Either it can be of myeloid lineage or it can be of lymphoid lineage, right? How
Mm.
to differentiate? Okay, what's acute? If you have more than 20% of blast cells, so it's known as acute leukemia.
Acute.
Okay, how to differentiate whether it's a myelogenous leukemia, like or the myeloid lineage or lymphoid lineage? Just for example, if they have myeloperoxidase or rods, it indicates that it comes from your myeloid lineage. If they have TDT, that is DNA polymerase, it means it comes from your lymphocytic
Lymphoid.
origin.
Mm-hmm.
There are a ton of MCQs in New World that is based on TDT and myeloperoxidase, right?
Mm.
Okay, so let's discuss ALL. Okay, so ALL is a commonly seen in children, right? Okay, I can say children, ALF
Mm.
or
Mm.
ALL,
Yeah.
right?
Mm-hmm.
So, okay, for example, if now I am studying the lymphoid lineage, right? Like I have just seen TDT, it means it's lymphoid lineage. So again, there is confusion that either it can be B like blasts that are of B cells or blasts that are of from T cells, right?
Mm.
Okay, you guys know that. How to differentiate whether these blasts are contributing in formation of B cells or T cells? Already
Mm-hmm.
done.
CD markers.
Yes, just look towards the CD markers. Okay, I just gave you a rough overview. Whenever you have less than 10, it indicates C cells till 8, right? And
Yeah.
whenever you have more than 10, 10 or 20, 21, 19, it indicates B cells.
B
So
cells.
if you have TDT and you have CD20, so you would say that it's BALL, right?
Mm.
If you have CD8, let's suppose, or CD4, it indicates TALL.
TALL. Mm-hmm.
Yes. So, okay, so it can be classified into BALL and it TALL, right? Okay. So BALL, okay. So how to do it would be having surface marker of CD10, CD19, and CD20, right?
Yes.
Okay. Okay. So basically, it have excellent response to chemotherapy, right? And it is basically seen in children. Okay, the TLL you are going to see CD2 to CD8, right?
Mm-hmm.
Okay. So this is how to differentiate. So you are also going to see an MCQs in UWorld related to it. If you know these receptor, you know the general rule: 10 lower than 10 for T cells, and greater than 10 for or 10 or greater than 10 for B cells. You also have a lot of MCQs on this too. Okay, so now let's come towards myeloid lineage. Okay, like we have covered. Okay, here I'll be referring again and again to this slide. Okay, so we have covered these blasts and these blasts, right? Now let's come towards these blasts. because still we are doing acute, right?
Mhm.
Okay. So, acute myeloid leukemia. Okay. So, again, if you are seeing blast cells more than 20%, whenever the word acute means, it means blast more than 20%, right? And
Right.
myeloid, now it's on the myeloid lineage side.
Mhm.
Okay. So, and you know how to differentiate it? They have myeloperoxidase, they have ore rods. Okay, one of your UWorld MCQs. What if this ore rods enter your blood? We have already
It
discussed
goes
it.
to DIC.
Yes, perfect. It causes DIC. Okay. So, we have already discussed it when we were doing the platelets, if you guys remember, right? So, okay, so it can also be classified into several types. For example, if I am having acute, like more than 20% blast cell in this myeloblast, so what would be the name for that? The name for that would be acute promyelocytic leukemia, right? Acute promyelocytic leukemia. It's acute, more than
20.
20% blast cells, right? So,
Mhm.
first of all, acute promyelocytic leukemia. Okay. So, in acute promyelocytic leukemia, basically what happens, you have a translocation of 15 and 17.
17.
Okay. So, you guys must remember that basically what happens, you have disruption of one of receptor that is known as retinoic acid receptor, right? So, if we have disruption of a retinoic acid receptor, it means they cannot be converted into mature cells. It means that the immature side would keep on building up inside your bone
Mhm.
marrow, right? So it would lead to acute promyelocytic leukemia, right? And what's the treatment? Give them all trans retinoic acid, derivative of one of vitamin A. So it would help these cells to move from this immature and move towards mature, and eventually they will die, right? So their concentration is going to decrease. So this was the idea of acute promyelocytic leukemia, right? Okay, then you can also have, okay, the main important take home point, 15, 17 translocation, retinoic acid receptor disruption, give them all trans retinoic acid.
ATRA.
This is one of your UWorld MCQs, right?
Ultra. Yes.
Okay. Then you can also have blast proliferation of the monoblast as well, right?
Mhm.
Okay. So now let's, okay, that would be acute monocytic leukemia. Okay, but basically the acute monocytic leukemia, like this part, they won't be having MPO. Why? Okay, they won't be having MPO as well as the megakaryocytes, acute megakaryoblast leukemia. They also won't be having MPO. Sorry. Yes, they do not carry oxygen, right? And you know that the blast cells, that megakaryoblast, they do not have nucleus as well. Only the fragments are going to become apart and they are going to be converted into platelets, right? So that they won't be having this enzyme, right? But for acute monocytic leukemia, you guys must remember that you can have blast character. These blasts can enter your gums. They love to infiltrate into your gums. High yield, right?
Mhm.
Doctor,
They
can you please
love
repeat the last part from
which part?
acute monocytic leukemia?
Okay, so we are done with acute promyelocytic leukemia, right? Now let's discuss, for example, if we have more than 20% of monoblast. So that condition would be known as acute monocytic leukemia. If you have more than 20% of megakaryocytes, it means it would be known as acute megakaryoblast leukemia, right?
Right.
Okay, but they won't be having MPO. That is this enzyme which helps kill your bacteria. the monocytes, right? First of all, like they are immature, right? These monoblasts are immature. Once they are converted into macrophages, then they can fight off the uh, infections, right? And related to megakaryoblast, they do not have nucleus in order to make this MPO. So both of them would be lacking MPO. Simple. Okay, but these monocyte, that monocytic blasts, these blasts loves to go into your gums. So you are going to see some gums infiltrate of these blasts. Okay, is that clear now?
Yeah.
Hello. Okay.
Yes.
Yes, thank you.
Okay, so acute monocytic leukemia may also arise from dysplasia as well. Okay, so myelodysplastic syndromes can also cause it. So now let's move towards. Okay, so we are done with all of these blasts, right? Now let's move towards chronic leukemias. We have already discussed here. This is neoplastic proliferation of your mature cells, right?
Mature cells. Yes.
So neoplastic proliferation of your mature cells, right? Okay. So now let's discuss the type as well. For example, now the question arises whether it's on the lymphocytic lineage or myeloid lineage, right? Lymphoid lineage or myeloid lineage. So if it's present inside your, or if you have mature cells proliferation on the myeloid lineage, it would be known as chronic lymphocytic leukemia, right?
Mm-hmm.
And if you have mature proliferation on the myeloid lineage, it would be known as chronic. Yes,
Myelocele.
it would be known as, okay. That is basically known as multi-proliferative disorders. Okay, multi-proliferative disorders. Okay. So now let's discuss chronic lymphocytic leukemia. Okay, again, it can arise from your B cells. Okay, so if it's arising from your B cells, hello.
Yeah.
Okay. An important thing which you guys must remember here. Okay, let's come to this chart. So you have naive B cells and then you have mature B cells as well. What's the difference between naive B cells and mature B cells? Whenever the B cells aren't exposed to antigen or they are newly formed, they are known as naive B cells, right? When they are exposed to antigens, they are basically known as mature B cells, right?
Plasma cells. Yeah.
Yes. So you can have chronic, like lymphocytic proliferation of naive cell as well as mature B cell, right?
Okay.
Okay. So now let's discuss neoplastic proliferation of naive B cells. Okay, the chronic lymphocytic leukemia. So neoplastic proliferation of naive B cells. Okay, what would be the surface markers? CD20 and CD5. Yes. Now here we are moving from the normal mnemonic that we had made, that all the receptors that are okay. This is basically receptor of your T cells, right? Less than 10. But here you guys must remember that in chronic lymphocytic leukemia, you are whenever it involves the naive B cells, you are going to see CD20 along with CD5. It's an exception. Just remember that exception, right? If it's exception, it means it's high yield. Okay. So you are also going to see a characteristic cells that are known as smudge cell. Okay, what's smudge cell? Simply take B cells and hit it with, you know, just slap it
Mm-hmm.
against the wall. Okay, then you will get smudge cell. That is smashed B cells, right?
Mm-hmm.
Okay, on the blood smear. Okay, so if we have neoplastic proliferation of B cells, it means the lymph nodes are also going to be involved. Okay, in case of B cells, which part of lymph nodes would be like
Follicles.
enlarged follicles? Yes. So we can also see generalized lymphadenopathy, right?
Right.
Generalized lymphadenopathy. Okay. If we have defect of B cells, it means it won't be making enough immunoglobulins. So you may also see hypogammaglobulinemia, right?
Mm-hmm.
Okay. It means it would be releasing less immunoglobulins. And whatever immunoglobulins it's releasing, you can also see autoimmune hemolytic anemia. These immunoglobulins would mark your red blood cells and would destroy them. If you guys remember, you have two types. That is the cold and warm, right? IgM and IgG, bound to red blood cells.
Yeah.
Okay. So it can also cause autoimmune hemolytic anemia. Simply, and it can also transform into B cell lymphoma, where you are going to see cancer or like lymph nodes being enlarged, right? Okay, neoplastic proliferation. Okay, now let's discuss chronic, that is mature, okay, again, mature neoplastic proliferation of your B cells, but this time the mature B cells.
Mm-hmm.
What's the name for that? It's hairy cell leukemia.
Oh.
Okay?
Mm-hmm.
Okay, don't worry, we are going to have an overview of it, and you guys are going to. Okay, what happens in mature neoplastic B cell proliferation? As the name indicates, you are going to see the. Okay, so the cytoplasm would just have a hairy like projection. That's why it is known as hairy cell leukemia, right?
Mm-hmm.
Okay, so the cells are positive for TRAP. So let me just, guys, give you a mnemonic. What is TRAP? It's titrate resistant acid phosphatase,
Mm.
right?
Yeah.
Okay, you are also going to see splenomegaly because this, B cells can accumulate, these hairy cell can accumulate inside your spleen and it can just enlarge your spleen, right?
Mm-hmm.
Okay, what can be some of the treatment option? If you guys remember, we discussed a condition that was severe um, SCID, severe combined immunodeficiency disease.
Immunodeficiency.
One of the cause was that if we have deficiency of adenosine deaminase, right?
Right.
So adenosine and amines are going to
Increase.
build up to a toxic level, and it would destroy the T lymphocytes, right?
Mm-hmm.
So we can use it here as a treatment option in order to kill the extra mature B cells. Okay, just give them adenosine deaminase inhibitors. Okay, so you can also have adult, that is T cell leukemia.
Dr. Ahmed, can you please repeat that recent part, the inhibitor?
Okay, so in severe combined immunodeficiency syndrome, we discussed that it can. What's the basic idea behind severe combined immunodeficiency syndrome? If both your B cells and T cells are
Deficient.
breaking, yes, deficient, and
Mm-hmm.
there were certain reasons. For example, if you do not have MSC2 receptor, and one of reason was if the adenosine and adenosine combined with amines. Normally, you have adenosine deaminase in order to cut the bonding between adenosine and amines
Amine
because they are
group.
toxic to your cell.
Wow.
Okay, so
Yeah.
what can we do? Normally we can give them this inhibitor in order to increase these levels and in order to increase these and cause toxicity of these B cells, so these neoplastic proliferated B cells would die.
Okay. Got it. No.
Yes, if you guys remember, we have
Dr. Ahmed, we cannot hear you.
hello, hello.
Yeah, you're audible now. Mm.
Okay. Like the idea is that we have already discussed one of the condition that is nephrogenic diabetes insipidus, which is caused by cyclophosphamide.
Mm-hmm.
It was cyclophosphamide or right? It was cyclophosphamide, right? No. Lithium and
Lithium, of course.
lithium plus demeclocycline. Yes.
Yes.
Yeah.
Okay. So like demeclocycline causes nephrogenic diabetes insipidus, but we can give demeclocycline in SIADH in order to decrease the responsiveness. So similarly, you can remember it that in one condition it was just causing a pathological condition like here in SCID, but we can use this implication as therapeutically, like we were using in SIADS. So just increase the adenosine levels and the cells would die. Like the cancerous cells would die. Simple.
Okay.
Okay. So now let's discuss the T part. the T cell part. Okay. So whenever you have neoplastic matured CD4 positive T cell accumulation, okay, what are the associated features? It can be due to HPLV1. That is T cell. It's a virus which is going to induce proliferation in T cells. Simple.
Mhm.
Okay, and if you have proliferation of your T cells, again, you are going to see generalized lymphadenopathy, right? All of the lymph nodes, the paracortical area is going to be enlarged. So you are going to see generalized lymphadenopathy. Secondly, you are going to see hepatosplenomegaly as well, right? So this was all about acute leukemia and chronic leukemias. Anyone who can just give us an overview of all these leukemia looking towards this picture. Yes. Acute lymphocytic
That is the
lymphoblastic.
that is like acute and chronic, the 20% criteria.
Yes. Okay. Okay. Yes. Yes. Perfect. Yes. 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 Perfect. Perfect. Guys, like here in this WBCs, if you know the general overview that Dr. Al Future is talking about, you guys can easily answer your U World MCQs, your NVMEs MCQs. Like you only have to differentiate, like the 20% TDT, this, that. You don't have to go in the details that you're going to see this, that. Like it's a kind of, like if you have general overview of all of this, so you can easily answer your MCQs. Okay, yes, Dr. Al Future. Yes. Okay. Yes. Oh, no, you are just confusing. B cells are above.
Mm.
Yes.
Yeah.
Yes. Okay. Now let's move to chronic. Yeah. On the lymphoid side, yes. Okay, let me give you a mnemonic. You know, mature people have ears, right? So mature B cells proliferation, here is cell leukemia. Okay. So, yes. And here you have an exception, CD5. Yes, perfect. If B cells are increasing, you have a general overview. The follicular portion is going to increase everywhere inside your lymph nodes, so you are going to see lymphadenopathy. You know the immunology. If B cells are affected, the IgG, the antibodies are also going to be affected. Hypogammaglobulinemia, this, that. You guys know how to treat. You guys know um, deaminase inhibitor. Like
Inhibitor.
these,
Yeah.
these are some general kind of things which you guys, if you guys have done your immunology well, as I told you, you guys can easily predict of what's happening next, right? On the T side, on the lymphoid side. Okay.
Mm-hmm.
Yes. Nodal features. Yes. And CD4 one. Perfect. So now let's move towards the myeloid lineage, right? So whenever you have chronic increase of myeloid lineage mature cells, they are basically known as myeloproliferative disorders, right? Myeloproliferative myeloid side, like mature cells are proliferating, as the name indicates, right? So you can have proliferation of different lineages. For example, if you are having proliferation of your, let's suppose, okay, let me come here. Okay, these the myeloid, this part, that is neutrophils, basophils, and eosinophils. They are mature, right? Whenever you have proliferation of these three cells, so it would be known as chronic myeloid leukemia, right? Chronic myeloid leukemia. Whenever the chronic leukemia come, you know you are going to see basophilias. Like as compared to all of these three cells, basophils are going to increase more, right?
Mm.
Basophils are stained blue. One of your UL MCQ, basophilia. Another thing which should come in your mind, you have translocation of which chromosome? Philadelphia
922.
922.
922.
Okay, perfect. So now let's move and discuss chronic lympho or chronic myelogenous leukemia. So what happens in chronic myelogenous leukemia? You have neoplastic proliferation of matured cells, all of the granular side, especially more of basophil. 922 translocation. What's 922? BCR and ABL gene. One of your UWorld MCQ. You guys
Mm-hmm.
must have done this MCQ, right? So what happens? What's the concept here? Whenever Okay, so the ABL basically increased tyrosine activity, kinase activity, right? So BCR is the normal gene for inside your like basophils, for example. So if you are replicating ABL as well, it means the tyrosine kinase activity is going to be increased. Like for example, this is your cell. You know tyrosine kinase is the second messenger system, right? Like, okay, if I'm increasing these messages to make more and more basophils, to make more and more eosinophils, so they would build up. Whenever they build up, it's known as CML. Simple. Hello. Okay, how to block off this tyrosine kinase activity? Yes, give them monoclonal
Thyroid.
antibody. What's the name of that? Imatinib.
Mm-hmm.
Very high yield. You are going to see an MCQs on it. Okay, let's make mnemonic for it. Tyrosine kinase, tyrosine kinase in CML, you need imatinib. Okay, you have a man that is Iman. He undergoes CT scan, right? Right?
Yeah.
Hello? So imatinib for CML, that is, it blocks of tyrosine kinase activity.
Yeah.
Okay? So imatinib, very high yield, you are going to see an MCQ on it. High yield, okay? So just give them imatinib. Okay, so it can also transform into, okay, another thing. It can also transform into like AML and ALL as well. Like you can see, for example, the CML, we are talking about it. It can transform to CLL as well. How? Because you have genetic association. It means you are going to see problem somewhere here in the hematopoietic stem cell, right? So it can either go here or here. So CML, if there is a genetic tie-in, it means it have two pathways to go. Like it can also progress into lymphocytic pathway as well, because something is wrong with your genes. Okay, so this was all about CML and the important concepts related to CML. Okay, now let's discuss another condition, polycythemia. Polycythemia vera. Okay, you have a pathway, second messenger pathway, that is known as JAK2 kinase, right? Whenever you have mutation of JAK2 kinase, what's the idea? Okay, normally what happens, your EPO is going to come. Okay, where is EPO is going to come from? Interstitial cells of your peritubular capillaries, right?
Mm.
It's going to come into your bone marrow. It's going to tell your bone marrow to produce more of red blood cells, right?
Mhm.
Via, it would sit on this receptor and it would increase the JAK2 kinase activity. And as a result of that, red blood cells would increase. What if something happens and without binding EPO, this JAK-STAT pathway increases? This JAK-STAT signaling pathway increases. It keeps on sending more signals. If you have certain mutation, again you are going to see more red blood cells, but this time without any EPO coming and stimulating it, right?
Mm.
So if you have mutation of this pathway, and as a result of that, you are sending more signal to the nucleus to make more red blood cells. So it's basically polycythemia vera. Hematocrit is increased. In new world, we have a person. He's bathing, and right after that, he have an hypersensitivity reaction. He's just having itching, and he's scratching him off. So whenever you have history like that, it indicates polycythemia vera, right?
Mhm.
Because this like this okay, it was a cold shower or hot shower? I guess it was hot shower, right? Or cold shower.
It's normal water, like it's
Okay,
aquagenic.
Yeah.
okay. So you are going to see degranulation of your mast cell as well, and they are going to induce hypersensitivity and itching. Simple. So you are of okay, if the hematocrit is increased, it means it would run slow in your blood vessels. What if it comes to your eye? So it can, I mean, it's moving slow. Simply, you can think of what happens. You can see blurry vision. You can see congestion.
Mhm.
Okay, so this was all about, okay. What will happen to the level of EPO? Negative feedback. It would be less.
Mm.
Okay. So if we have more EPO and more hematocrit, what do you guys think could be the condition associated with it? What have happened? Okay, increased viscosity, but if
It
you have
can be
more,
Chronic kidney,
exogenous.
chronic kidney disease.
No, it
okay, so
can
in
be.
chronic kidney disease, EPO decreases, I guess.
Any tumor,
Uh,
EPO-secreting tumors?
yeah, any
Yes, yes,
malignancy or
yes,
else exogenous EPO.
In hypoxic condition.
yes, hypoxic.
Yes, so hypoxia triggers the.
Mhm.
For example, if person is on high altitude for a long period of time, so you will be seeing more EPO, and along with that, you are going to see more. Yes, hematocrit. Okay. So now let's discuss another condition, that is essential thrombocythemia. That is increased proliferation of mature myeloid cells, especially platelets. If you have more platelets are mature, right? It's known as essential thrombocythemia. Okay, if you have more platelets being produced, it means what happens? There is increased risk of bleeding, thrombosis. Okay, and you know that. Okay, okay. Let me give you another concept. Like for example, if you are increasing more like for example, if we have like neoplastic proliferation of mature red blood cells, that is polycythemia. So you know the cellular turnover is increased. Hello. So it can lead to gout, right? Okay, if you are increasing the cellular turnover, you are breaking off more of purines, right? If you are breaking more of purine, uric acid can come. Okay, the salvage pathway, uric acid can accumulate in different joints. It can give you the outcomes of gout, right? Because they have nucleus. But platelets do not have nucleus, so there would be no risk for gout, right? They do not have nucleus, no DNA, right? If no DNA, no uric acid formation. Okay, so if they are producing more, it means like it's a neoplastic process going on. The platelets won't be performing their function well, so there is increased chances of bleeding as well as thrombosis as well. Okay, so if we have mature proliferation of mature myeloid cell megakaryocytes here, that it can be due to megakaryocyte or platelets. Wait, let me come here to the this picture. Like you can, okay, megakaryocytes, they were also mature, platelets were also mature. You can have proliferation of platelets as well and megakaryocytes as well. If you have more platelets, we already discussed. It can also be due to JAK2 kinase mutation, right? Okay. And this can also be due to JAK2 kinase. Okay. So now we have already discussed platelets. Now we are discussing megakaryocytes. So megakaryocytes proliferation is also associated with JAK2, right? And but another thing, these megakaryocytes are going to produce a factor that is known as platelets derived growth factor. You know, platelets derived growth factor and TGF beta are going to increase and are going to stimulate your fibroblasts, and you are going to see fibrosis, right?
Mhm.
Okay, so what happens inside your bone marrow? You will be seeing extensive fibrosis, right? So, for example, now if the cells are being produced and they are just crossing over this meshwork, right? This meshwork of fibrosis. So the when the cell would like struggle to move through these fibrosis. So the cell would just like, for example, if this cell is struggling to move out, so it would move out like that, like a teardrop, right?
Yeah.
All of his shape is going to be disrupted due to this meshwork. So you're going to see teardrop cells.
Mhm.
You're going to see dry tap. Whenever you are injecting the needle, the fibrosis or the fibrin that is being accumulated here is going to give you dry tap, right?
Right.
So this was all about. Okay, we are done with chronic as well. So Dr. Al Futures, please just discuss the chronic side of myeloids. Okay. Yes. Yes. Okay. CML 922 translocation, increased basophil. Your UWorld MCQ. Just discuss that as well. Okay. Then yes. Essential thrombocythemia. Yes. Gout. Uric acid. Yes. Yes. So you can see MCQs related to this concept. Okay. You will be okay. Another megakaryocytic, dry tap, fibrosis, platelets derived. Yeah. Perfect. So let's have 5 minutes of break. Then we are going to finish off lymphadenopathies, right? Okay. Hello.
Yeah,
Yes,
okay.
doctor.
Okay. Thank you. Okay. What is lymphadenopathy? Whenever your lymph nodes are enlarged, simple. It's known as lymphadenopathy. So you guys know that lymph nodes can be enlarged in two situations. One we discuss in immunology section. For example, if you have an infection going on, it means your lymphocytes are going to be activated. That is B cells, right? B cells can undergo hyperplasia, right? Right? And they would just try to make those B cells which are compatible with the antigens, right? So there would be a turnover. Like some of the B cells are going to be produced as well as they are going to die off. Those B cells which aren't compatible or which do not have same uh, same pattern of your antigens, they are going to die off, right? How would they die? Your macrophages are going to come, they are going to kill those B cells which cannot kill your antigen. Simple. Okay, so one situation you have infection, B cells would undergo hyperplasia. They would just try to find the, they would just try to make best match for the antigen, right? As we discussed, if you have 1, 2, 3 antigen, your B cell is going to produce 3, 2, 1, 1, 2, 3. Okay, once it form 1, 2, 3, it would just kill the remaining. Simple. So for the killing, you would see macrophages there inside your lymph node, right? Hello.
Yes.
So these macrophages, which are killing the incompatible B cells, that are basically known as tangible bodies. Okay. Another situation in which your lymph node can enlarge, for example, if you have neoplastic proliferation of your B cells, let's suppose. So it can also lead to enlargement of your lymph node, right? But it's a neoplastic. It means the pattern won't be same. Like in this case, you are only going to see follicles being hypertrophied or hyperplasia. You're going to see, but there would be a kind of disrupted kind of growth because it's an abnormal, cancerous kind of growth, right? But in this case, you won't be seeing macrophages, that tangible bodies. Another thing, if whenever you have infection, so you are going to see lymphadenopathy, right? Like enlargement of your lymph node due to hyperplasia, already discussed. It would be painful, very high yield. And in case of lymphoma or any cancer, it would be painless. So whenever you see in your world that person appear, he have painful lymph nodes, just go for this. And if it's painless, just think of some kind of lymphoma or neoplastic proliferation going on, B cells, right? So this neoplastic proliferation is basically known as lymphoma. Lymphoma. Okay, so there are various types of lymphoma. It can be known as non-Hodgkin lymphomas and Hodgkin lymphomas. Okay, which one are more common, non-Hodgkin or Hodgkin's? Hello? Hello?
Non-Hodgkin.
Okay, which?
Hodgkin?
No, non-Hodgkin is more common.
Non-Hodgkin.
It's more common. That is 60% of non-Hodgkin lymphoma. You're going to see 40% population with Hodgkin lymphoma. So non-Hodgkin lymphoma can be further divided into B cells or T cells, right? If you have neoplastic proliferation of B cells. Okay, so it can be okay based on the size of B cells. B cells size. Non-Hodgkin lymphoma can be divided into three categories. That is small B cells, right? Your intermediate size B cells and your large B cells. Okay, so the small B cells is further divided into follicular lymphoma, your mantle lymphoma, and marginal lymphoma. Just don't confuse yourself with follicular, mantle, and marginal because you know this is your lymph node. So you have follicles in which B cells are sitting, right?
Mm-hmm.
Okay, so close to the follicle, this area is basically known as mantle area.
Okay.
Okay, and close to mantle area, you have marginal zone.
Marginal.
And then you have your paracortex, right?
Right.
So follicular lymphoma, it's example of small B cells lymphoma, that is non-Hodgkin lymphoma, right?
Right.
Small B cell lymphoma, type of Hodgkin lymphoma, the most common one. Okay, so whenever you have neoplastic proliferation, okay, let me write it, neoplastic proliferation of small B cells that are growing in the form of follicles, like these follicles are growing and it have the shape being maintained, the follicle shape is maintained, but it's not as that of as normal follicles, right? But still you can differentiate the follicles and mantle part, right? So it is that or based on its appearance, based on its location, it's divided into follicular. Those who have well formed follicles nodules, they are known as follicle lymphoma. That is example of small B cells, CD20, guys, and it would be painless, right? Hello.
Yeah.
Okay, so are you guys getting me or not? Yes. Non-Hodgkin and Hodgkin. Non-Hodgkin common. Hodgkin less common. Non-Hodgkin basically divided on the cell size: small, intermediate, large. Small furtherly divided into if they have follicle, if only follicles have the B cell, neoplastic B cells, it's known as follicular. And you know the other. For example, if you have invasion of these follicles into mantle zone, it would be known as mantle cell lymphoma. If you have marginal zone involvement, it would be known as marginal cell lymphoma. Simple.
Mm-hmm.
Okay. So neoplastic small B cells follicles. Okay, what's going on? Okay, if you guys remember apoptosis, what happens in apoptosis? You know, inside your mitochondria, you have cytochrome C,
Mm-hmm.
and one of your molecule that is present in the walls of mitochondria, that is known as BCL2, right? So it would not let this cytochrome to leak out into cytoplasm, right? Normally, BCL2 sits here. So it's okay. Once okay, what happens when the cytochrome C come out? It's going to activate caspases. What is caspases? These are the enzymes which would cleave your nuclear material, which would cleave your protein, and ultimately your cell will die.
Mm.
This is apoptosis. Okay. Normally on the 14th chromosome, you have genes which encodes your heavy chain, IgG heavy chain. That is Ig heavy chain. You know the heavy chain and light chain, which we have already discussed. Heavy chain and light chain and heavy chains. So what happens? That you have translocation of 14 and 18. On
18.
the 18, basically you have BCL2. And on the 14, you know, you have IgG heavy chain.
Mm-hmm.
Like normally, your B cells need 14 chromosome. chromosome number 14 genes, right? In order to produce Ig. But what happens if you have translocation? What's translocation? The 18 go and it bind with, they have good friendship with one another, and 18 just takes advantage of 14. Once it is replicated, so 18 also replicates,
Mm.
right? If 18 is replicating, it means you will have more BCl2. More BCl2, it means apoptosis decreases.
Mm.
If apoptosis decreases, what happens? It's cancer. More B cells,
Yes.
right?
Yes.
Okay. Okay. There won't be any tangible bodies if you guys remember. Tangible bodies, no macrophages. Tangible bodies are only present in infections. That macrophages, tangible bodies. Okay. So disruption of the normal, the lymphoid architecture is also going to be disrupted. Like normally the follicles aren't that big, and but now you have small B cells, neoplastic B cells, so the follicles are going to become very big. So the normal architecture is also disrupted. Then you have another lymphoma, mantle cell lymphoma. You know, it's also small B cells, right? But when they invade the mantle zone, right? If they invade the mantle zone, it would be known as mantle cell lymphoma, right?
Yes.
Okay. You know what is mental hospital? Okay, just remember a person in mental hospital is driving cycle. Remember.
Psychological disorders.
Okay. Yes, it's
Cycling
psychological.
diva.
Okay, psychological disorder. Like in mental hospital, you are going to see individual with psychological disorder, right? Or let me write cycle,
Right.
psychological. So in this, you are going to see translocation of 14 and cyclin D.
11, 14.
That is 11,
11,
14.
14. Mm-hmm.
On
Yeah.
11, you have cyclin D. What is cyclin D1? Cyclin D1 increases, okay, it pushes the cell to move from G1 to S phase. What is S phase? Synthesis phase. It means if I have, okay, cyclin have come, it bound itself with the Ig heavy chain. So now it would be also replicated more. So it would be pushing more cells to move in the synthesis phase. So
Right.
I'm seeing more cells. More cells, again lymphoma, cancer.
Yeah.
Okay. So you guys should remember the mental driving a cycle. Simple. Okay. Then marginal zone. Whenever these small B cells enter the marginal zone, it's known as marginal zone lymphoma, right?
Mm-hmm.
But this time it's associated with chronic inflammatory disorders like Sjogren syndromes, like Hashimoto's thyroiditis, right? So it can also happen in the mucosal sites as well. If you, as you guys have already discussed, that is MALT. What is MALT? Mucosa, associated lymphoid tissue,
Lymphoid
fire
tissue.
patches.
Mm.
They also have lymphoid tissues, right? They also have follicles. They also have mantle. So it can also happen there. Simple. Okay, we are done with the small. Now let's come towards intermediate, right? Intermediate size B cells. So in intermediate size B cells, you have Burkitt lymphoma. What happened in Burkitt lymphoma? Again, EBV virus is going to, and classic. Okay, you are also going to see in MCQ in U world. You guys must have done that. If you have an African, if you have an African child, and he is having enlarged lymph node on his jaw
Submandibular jaw.
or mandible,
Mm.
so just go for,
But
yes,
it's,
Burkitt lymphoma.
yeah.
Okay, so okay, this okay. What happens in Burkitt lymphoma? Again, you are going to see 14 and 8 translocation. What's there on 8? On 8, you have CMYC, and CMYC promotes your growth or growth of your cells.
Mm-hmm.
Again, if I am producing more CMYC, it means the B cell growth is going to be increased more. More growth, cancer. Simple. Okay, then you have diffuse large B cell lymphoma. Then you have large cell. Large. So what's the name of that? Diffuse large. Diffuse, it means you're going to see it in diffuse in different parts, right, of your lymph, different lymph nodes. Hello, and it's like the most aggressive type of tumor or lymphoma. So this was all about the non-Hodgkin lymphoma. Now let's come toward Hodgkin lymphoma. The first thing which come in your mind related to Hodgkin lymphoma, yes,
Reed Steenberg cell.
yes, Reed Steinberg cell, like owl eyes kind of cell, right? Owl eyes. Okay, what happens? Like basically, you won't be seeing more B cells. Like you, okay, it's a lymphoma. It means lymph node is going to be enlarged, cancerous enlargement. But now in this scenario, it's not due to accumulation of B cells. It's only these Reed Steinberg cells would be producing cytokines, and cytokines are going to recruit more of inflammatory cells, that is macrophages, lymphocyte, and these macrophages and lymphocyte would keep on accumulating inside your lymph node, and as a result of that you will be seeing enlargement of lymph nodes. So this is one of your UWorld MCQs, Reed Steinberg cell, and they are going to produce cytokines, and these cytokines are going to recruit inflammatory cells, and as a result of that you will be seeing Hodgkin lymphoma. Simple. Okay, so there are various type of Hodgkin lymphoma as well. Okay, that is nodular sclerosing, lymphocyte rich, as the name indicates, more lymphocyte, mixed cellularity, like mixed kind of cells have formed that lymphoma, or lymphocyte depleted. All of the inflammatory cells are more except that of lymphocyte, as the name indicates. Okay, so what happens in, okay, the most common among all of them is 70% nodular sclerosis, right?
Mm-hmm.
Okay, you're going to see enlarging cervical and mediastinal lymph nodes. Okay, and you're going to see band of sclerosis, like that, sclerosis inside your lymph nodes. Okay, so lymphocyte rich. Okay, important thing which you guys must remember that lymphocyte rich have the best prognosis of all. Lymphocyte rich have best prognosis, and lymphocyte depleted have poor prognosis. Okay,
Mm-hmm.
so this was all about the lymphomas. Now let's discuss our last topic, that is plasma cell disorder or dyscrasia. Okay, what's plasma cell dyscrasia? Yes, anyone? Yes, whenever the plasma cells have cancers, neoplastic proliferation, it's known as plasma cell dyscrasia. Okay, and what would be certain clinical features? Yes, what would be clinical features? Lytic bone lesions. Why? It would increase the rank L activity. Once the rank L activity increase, it would recruit more osteoclasts.
Mm-hmm.
Osteoclasts are going to break off your bone breaking. So what happens to the calcium level?
Increase.
Increases. Okay, if you have proliferation of plasma cells, you're going to see increased IgM as well.
Right.
Okay, so you'll be seeing an M spike.
Mm-hmm.
Okay, M spike. This is one of your UWorld MCQ. They are going to ask you. You're going to see an M spike in this. Okay, the monoclonal antibodies lack antigenic diversity as well. Okay, you are going to see Rolu or Rolex formation. Okay, what's Rolex? Okay, what's Role or Role, or some people call it Rolex? Just remember of the Rolex watch, right? So what are you going to see? Red blood cells sitting upon one another, like that.
Right.
Okay, forming a Rolex watch. Okay, okay. So whenever you have, okay, what does it indicates? The basically the charge. If you have increased plasma cell activity, so you are going to see more charges, that is negative charges, and these charges are going to attract one another. Simply it's a concept like that, and red blood cells are going to sit upon one another and it would form Rolo formation, right? Okay, if I have more immunoglobulins, it means more, yes, light chains. Immunoglobulins have light chain. These light chain can deposit in several structure, giving you amyloidosis as well, right?
Mm.
And if these light chains are exiting inside your urine, what are they called?
Bench, John.
Yeah, Benz Jones, one of your UWorld MCQ, Benz Jones protein. Okay, so it was all about lymphoma. I just focused on the high yield points, UWorld MCQs. So hope so you guys enjoyed.
Yeah,
Like you know,
Dr. Ahmed, can you please repeat the starting where you started with this, right where your screen is displaying before the Hodgkin's and non-Hodgkin's, the tangible bodies you were saying.
okay,
Um,
okay,
Immediately after the break you started.
oh, sure, sure.
Yeah, this one. Oh, you went. Yeah.
Okay, so we were discussing about lymphadenopathy. What's lymphadenopathy? Enlargement of your lymph node. Lymph nodes can be enlarged in two situations. For example, if you have some infection going on, right? So it means you need more lymphocytes in order to fight off those infections, right?
Right.
More B cells turnover, millions of B cells being produced and million of B cells being they'll be they'll die off,
Right.
and macrophages are going to come in order to kill them, and it's a feature of your infections, right? In
Right.
infections that happens. So whenever you have macrophages inside your lymph nodes, they are known as tangible bodies. And
Okay.
okay, it would be painful, but lymphoma are painless with no tangible bodies.
Okay.
Okay. Dr. Renu, please give us an overview of lymphadenopathy till end. I think we have made it very easy.
Um, okay. So, whenever we have any infections, so the lymphocytes will come to fight it off. And hello?
Yes.
Yeah. So the lymphocytes will come to fight it off, and we will also see macrophages. So like they are like accumulated inside the macrophages, right?
Macrophages come to okay. Lymphocytes are going to undergo like division inside your lymph node,
Yeah.
and your macrophages are also going to come inside the lymph node in order to remove the incompatible B cells.
Okay. Mm-hmm.
So these macrophages are known as tangible bodies.
Tangible bodies, yeah, and it's a painful situation.
Yes, painful situation. And lymphoma is painless, right?
Painless, yeah.
So, okay, let me give you guys an overview. So, lymphoma is basically divided into two types: non-Hodgkin lymphoma, Hodgkin lymphoma. Non-Hodgkin lymphoma is the common one. Hodgkin is like less common, that is 40%. Non-Hodgkin can be then divided on the basis
Size
of
of
their
the
cell size, like B cell size. So you can have small B cell, intermediate size B cell, and large B cell.
large B cells.
Small B cells, it can be due to what's the type inside a small B cells? Follicles, follicular carcinoma. Okay, follicular lymphoma. So it's basically translocation of 14 and
18.
yes, 14 and 18. Okay, then you can have invasion of these B cells into the mantle zone. So it is basically known as mantle lymphoma. Whenever these B cells invaded into the marginal zone, it's known as marginal cell lymphoma. Mantle driving cycle. Okay, so cyclin D is going to increase. It's going to push cells from the G phase into synthesis phase. More cells, lymphoma. Okay, then you have your marginal zone. Marginal zone. It's basically 14 and anyone.
11.
Okay, 11, 14 translocation. Now it was mental. What was
11,
marginal?
14 is mental.
18. 14, 18. No, marginal one, 11 and 18. Mental, I guess, 14 and I think 11. Yeah.
Okay. So then your marginal cell lymphoma. Okay, marginal B cell lymphoma. Then you have your intermediate size. That is Burkitt lymphoma, African boy with jaw mass. Basically indicates Burkitt lymphoma. It can be due to ABV as well. 14, 8. 18 is cemic. Cemic increases cell growth. If cell growth increase, again you are going to see lymphoma. Then you have large diffuse type, right? It's present everywhere. It can be everywhere inside the lymph nodes. Then you have Hodgkin lymphoma. Important point: read Sternberg cells. These cells are going to produce more cytokines. Cytokines are going to recruit more of inflammatory cells. Once these inflammatory cells get accumulated inside your lymph nodes, it's going to give you lymphoma, right? Then you have different types, nodular sclerosing, the common type, mixed cellularity, lymphocyte rich and lymphocyte depleted. Lymphocyte rich have good prognosis, lymphocyte depleted have poor prognosis. That was all for white blood cells. Hope so you guys enjoyed. Thank you for staying here and see you tomorrow. Tomorrow we are
Hi,
going to
Doc.
yes,
I have a question. How long
yes.
does this assessment last?
Okay, I have given 5 days for this assessment.
Okay, till
Okay, just count. I,
actually,
when the,
someone messaged in the group that it's for till today only. So I'm just asking for.
no, no, I already told you that it's going to be there for 5 days.
Okay, okay, thank you.
Okay.
And it has only respiratory and hemonc, right?
No, no, it have respiratory, it have hematology, it have immunology, it have platelets, it have everything. The main system, I just named the main system, Kalman. It's a title.
Okay.
Uh,
Does it involve dharma too?
it have no, no, Dharma isn't involved.
Okay. Just
We're going to do
respiratory,
Dharma in the
immunology,
next.
hemonc.
Yeah, we're going to do Dharma in the next grand assessment, right?
Okay. Okay. Thank you, doctor. Doctor, will you be discussing the cancer drugs?
Cancer drugs. Okay, yes, we can discuss that.
Yeah, please, like just an
Yes,
overview
yes,
of the
please.
mechanism.
That I got
Yes,
confused. I
please.
think you guys were asking for the immunosuppressants.
No,
Yes,
the
please,
cancer
doctor.
drugs, the leukemia drugs.
Cancer drugs, yes.
Cancer.
Oncology drugs.
Okay, okay, okay. I'll just arrange a session on that.
Yeah.
Yes. But from tomorrow, let's discuss MSK. We have already lost 2 days. 2 days of discussion on MSK. Then it's very difficult for me to cover all system all at once. So from tomorrow, let's start MSK. Then let's see. Tomorrow we'll be covering all anatomy of MSK, right?
Okay, doc. Thank you.
Okay, thank you guys. Thank you. Have a nice day. Thank you. Bye
Thank you,
bye.
doctor.
Thank you.